We are going to talk about the spinal infections. We have got two types of spinal infections. Either you have got non-specific pyogenic spine infection, I mean osteomyelitis, acute osteomyelitis of the spine and discitis, or we have got non-pyogenic or specific spinal infections like granulomatous infections, brucellosis, leprosy, fungal infections. We concentrate on the pyogenic spinal infections because it is much more common than the TB and the other specific spinal infections. Although acute pyogenic infection of the spine is uncommon, and because of the diagnosis is usually not considered, treatment is usually unnecessarily delayed. So pyogenic spinal infection either occur at the level of the posterior arch of the spine or disc space, I mean spondylodiscitis, or occur at the level of the facet joint, which primarily and mainly occur in the lumbar region, mostly around 60%. 30% of the cases occur in the thoracic region, and around 10% occur in the cervical region. And epidural abscess formation is around 7% of the cases. Risk factor for infections occur in the elderly patients around the 7th decade of life, occur in the patients who have got concurrent illnesses and infections, in the cases of diabetic, I mean immunocompromised patients, obese patients, malnourished, patients on irradiations, patients on steroid therapy, and the patients who have got chronic urinary tract infections. The other risk factors are invasive procedures like epidural injections. Trauma to the spine also is a risk factor, and smoking also is a risk factor for getting infection into the spine. Concerning the pathology, Staphylococcus aureus is responsible in 50 to 60% of the cases of pyogenic spinal infections. There might be gram-negative organisms such as Escherichia coli, Pseudomonas, and Proteus. These are increasingly evident, and also opportunistic infections are quite common in immune-compromised patients. The route of infections, either it's a direct inoculation during invasive spinal procedures like spinal injections, spinoscopes, or might occur after operations, after disc surgery or spine surgery, or it might be indirect, I mean hematogenous, spread from the pelvic infections or any distant site. The very old and very young patients and chronically ill patients, as I mentioned, are quite susceptible to get infections. The infection may appear to start in the intervertebral disc space, but it is more likely that the initial site is adjacent vertebra with secondary spread to the disc space, and further spread may be along the anterior longitudinal ligament to the adjacent vertebra and outward, and might form by this paraspinal soft tissue abscess. And these abscesses sometimes track along the muscle planes to the groin, like psoas abscess, to the buttock, to the lumbar regions, and the spinal canal itself is rarely involved. This slide shows the route of infection to the spine. Regarding the clinical feature, majority of the patients, around 90%, will present with pain and local and focal tenderness at the area of infections. Around 60% of the cases have got an associated fever as well. Some patients might present with root symptoms and signs, I mean root compression. So in the affected dermatomes and myotomes, they will have paresthesia, diminished sensation, and weakness of the affected myotomes and dermatomes. Some patients might present with deformity, muscle spasm, and meningeal irritations. In chronic cases, the patient might present with sinus formation, and some patients will present with unexplained septicemia. Regarding the investigations, in the complete blood count, we will see the white cell counts will elevate in less than half of the patients. ESR will usually elevate more than 50 in 80 to 90% of the cases. This ESR with the CRP used to assess the treatment. So when you have got a patient and give management, conservative management, you are going to assess your management by ESR by decreasing the ESR and C-reactive protein. CRP will elevate in around 80 to 90% of the cases. For sure, as far as we are talking about the pyogenic spinal infections, alkaline phosphatase will elevate, which is an indicator for osteoblastic activity in pyogenic infections everywhere in the musculoskeletal system. Blood culture will be positive in around 20 to 25% of the cases, and it is best to take it to have the blood culture when the patient is febrile. Urine culture may be valuable if urethral manipulations is considered to be the cause for the infections. Anti-staphylococcus antigen and Brucella and Salmonella should be conducted, and the last resource will be biopsy. The biopsy is needed not so much to confirm the diagnosis, but to obtain the material for bacteriological examination to know the type of the bacteria that you have got, and for antibiotic sensitivity. So you are going to isolate the bacteria and direct the appropriate antibiotic against the microorganism. So this is the main reason behind the biopsy. In the majority of the cases, you know the diagnosis, but you want to know the appropriate and the causative microorganism, which microorganism is that, and which antibiotic is sensitive to. Regarding the biopsy, you have got two types, either a closed one, needle guided under fluoroscopy or CT scan. Its accuracy around 70 to 85%, but it has around 30% of false negative. In 30% of the cases, the biopsied material comes back with the result that there is no infection, but in reality there is. The most informative one is the open biopsy. Accuracy is more than 80%. The false negative results around 14%. The biopsied material should be sent for microbiology, for gram stain, for acid fast stain, for aerobic, anaerobic, fungal, and mycobacterial cultures, and also should be sent for histopathological examination. For example, in tuberculosis cases, the histopathologist will confirm the presence of TB granuloma. Radiological investigations, X-ray may show no any change for several weeks. If the diagnosis is delayed, the examination should be repeated. Early X-ray sign is loss of disc height, collapse of the disc space, irregularity of the disc space, erosion of the end plate, and reactive newborn formation. You might see also soft tissue shadow, abscess, psoas abscess shadows. Radioisotope show the changes much more earlier than the plain X-ray, although it has got a high sensitivity, but the specificity is not like that. CT scan is quite good for delineation of the bony margins and involvement and degree of the destruction of the bones. It can be used as a guide for the biopsy taking. Sometimes it will show soft tissue invasions, but it is quite poor for outlining the neural elements. Also, it has got the risk for spread if it's combined with myelography. I mean, when you are going to inject the dye to see the peak much more better. MRI is the best. It's the most important investigations. It will show the soft tissue quite well, including the neural elements. It will define the abscess cavity if there's any quite precisely. If there is any extensive destruction of the end plate of adjacent vertebra, will be quite obvious. If there is epidural abscess, it will be quite obvious. So MRI is the most valuable investigation. This slide shows thoracic discitis with an associated epidural abscess and associated spinal cord compression because it's occurring in the thoracic area. The differential diagnosis will be specific spinal infections like tuberculosis and brucellosis. History, investigations, and radiological imaging is quite obvious in differentiation. Metastasis myeloma might mimic these spinal infections, but in metastasis and secondary bone tumor, usually the disc space is spared because the disc is barrier against spread of metastasis, but usually it's affected in any infection. It should be differentiated from degenerative disc disease. It's not difficult because there is no any signs of infection and the investigation are normal. Osteoporosis and local Sherman is quite easily can be differentiated from the spinal infections. Also spondyloarthropathies sometimes mimic spinal infection, but I think by history and examination and investigation it's not difficult to differentiate it from the spinal infections. Our aim and goal in the management is to establish the real diagnosis, clear infection and prevent its recurrence, get a complete pain relief, protect and restore the neurological function, maintain and or restore spinal stability. The battlefield, our target and territory is the patient, our enemy is the microorganism, and our weapons are antibiotic and surgery. Although sometimes our territory has been changed because the patient is immune compromised, has got transplant, or he's on dialysis, or he's chronic steroid user, or he's a drug abuser, or have got a malignancy elsewhere in the body. So it's not a good target to direct a traditional or ordinary treatment to act against him. Sometimes the enemy is changed because we might face some more resistant strain of microorganism, or we are going to fight against hospital-acquired infection that's leading to the spinal infections. It is as well important to know that the reasons behind inappropriate management is lack of the awareness in the surgeon side. He is using rubbish and empirical antibiotics, or he is doing inappropriate or inadequate surgery, or sometimes you are facing to have inappropriate patients. He have got no any patients, he is not abide by the surgeon's commands, he is quite negligible patient, and the consequences of this inappropriate management will have, the patient will have multiple surgeries, remain in pain, might get paralysis from compression of the abscess of sequestra, and the patient might die from septicemia, and so many financial costs for the community and the patient's family. We'll start with non-operative management, provided that diagnosis is certain and the organism is known by biopsy or guided biopsy, culture and sensitivity, and there is no any abscess, There is no any compression by abscess or sequestra. There is no any dead bone inside, and there is no any progressive neurological deficit. We will start 6 to 8 weeks of parenteral antibiotic, appropriate antibiotic. Usually we start with anti-staph, and followed by the similar period by oral antibiotic. Serial ESR and C-reactive protein examination is mandatory, although both stay high for the first 2 weeks of the starting of the treatment, and they are usually quite valuable, and they are used to assess our management. And antibiotics should continue for a month after both symptoms and ESR has turned back to normal. Also, we should have a radiological and MRI evaluation to see infection is stopped or became quite better, and there is no any deformity and bone destructions. The risk of conservative management is failure to control the disease. The antibiotic is best to be given according to the culture and sensitivity if you have. It should be of adequate dose and course, as we mentioned. We should monitor response by clinical and imaging and laboratory indices, ESR and CRP. And you should also take care of toxicity profile, especially if the hepatic and renal impairment patients. So, as part of the conservative management, any part under management should be rested. Spine should be rested. Absolute bed rest is mandatory to decrease pain and prevent deformity. Molded orthosis is quite good, whether lumbar or thoracolumbar orthosis. Hollow vest orthosis for the cervical spine and high thoracic might be mandatory. This slide shows pyogenic osteomyelitis of the L5 and S1 lumbar vertebra, lumbosacral region. With treatment, with conservative management, we see complete healing and ankylosis and fusion of the vertebra with the complete recovery. Sometimes the surgical management is mandatory. The indication will be failure of conservative management to control the disease. The diagnosed and organism cannot be confirmed, so you do open biopsy to know the real microorganism and to direct appropriate antibiotic against that, because the patient is not responding to ordinary antibiotics. If the patient has got neurological deficit and compression, it should be decompressed, particularly when there's epidural spread and epidural compression. If the patient has got mechanical instability, surgery is indicated, and you should stabilize the spine by transpedicular screws. Fortunately, titanium transpedicular screws is quite keen with the infections. We can use it quite easily. We should clear the disc space and place an autogenous bone graft for fusions. If there is an abscess and sequestra, for sure should be removed and raised appropriately. Our aim of management to drain any abscess if there is, to make the definitive diagnosis, to decompress the neural tissue, either root or the cord, according to the area of affection, to achieve the stability and rapid healing of the lesion by bone grafting. Surgery will be to the area of the pathology. If the disease is posterior, in the posterior arch we should go posterior. If the disease is anterior, we should go anterior. In the debilitated patient, it's possible to drain an abscess by posterolateral approach or by simple surgery. And thank you.